this week on the BackTable Podcast.
So yeah, that's what led me to leave CT. I do have one partner who brings in a C-arm in CT, and I think that's ridiculous. The cone beam CT today is so good. You know, like remove your inner stylet. When you're getting your pictures, you're going to get a great picture. You're going to see what you need to see. You can guide the case. It is so much faster, so much better. And techs get really good at doing it too after a while.
Oh, yeah, for sure. And I think these are very fun cases. I have yet to meet an IR tech who doesn't like a nice needle guidance case. And these are kind of the king of those.
They beg for it.
Yeah,
they do.
Exactly.
I was just at one of our other hospitals, and they have the capability. They always had the capability, but they just got a new Siemens machine, and they're like, "Can we do it on?" So we had a bunch of sacral ablations.
Awesome.
We want to do it on every case. All right.
Hello, everyone, and welcome to the BackTable MSK Podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. This is your host, Jacob Fleming. I'm here with another BackTable veteran, Jason Levy. Welcome back to the show, Dr. Levy. I think is this time number 3 for you?
Yeah, I think that's correct. It's been a while, but I think this is the third time.
Okay, lucky number 3, and it's overdue. I think today we're going to be talking about ablation of acetabular lesions, and I think this is a very important topic and has considerable interest in our community from a lot of our colleagues who are interested in bone tumor ablation and expanding the treatment options and being able to help more patients with that. So before we jump in, could you give us a little bit of review about your current practice, especially regarding bone tumor ablation?
Yeah, sure. So I am in a private practice in a hospital system, so I only cover one hospital system. We cover 3 of those hospitals. And the system is a very oncology-based system. So they have about 40, 45 oncologists that are essentially employed. They have hepatobiliary surgeons. They have, and in this case, we do have 2 sarcoma surgeons, Orthopedic Oncologists that I will work with in these cases. And, you know, as far as our practice, we're a busy bone tumor ablation practice. The majority of bone tumor ablation, across the country is going to be spinal or sacrum. And, the acetabulum is sort of an easy fill-in for your next step, in my opinion, is a axial weight-loading bone. That's commonly affected by lytic metastases or blastic metastases. So it's become an increasing part of our practice at my hospital here in Atlanta.
Tell me a little bit. Obviously, you are a world expert and respected for your involvement in the Opus 1 trial. You've been involved with spine tumor ablation for quite some time now. Tell me, how did you branch out into acetabular lesions specifically?
Yeah, I mean, it was something I was always very interested in, and as you point out, Opus 1, 206 patients, only 18 of them were in the pelvis and 9 were acetabular. So not a huge number. Now, the majority of those did come from our site, which was, something we're proud of, but it's still an infrequently used technology in that area, even though it's wide open. And I think a lot of that is we as interventional radiologists and other treating physicians did a lot of spine work, right? We were doing a lot of kyphoplasty, doing a lot of vertebroplasty, and we were doing it on oncology patients, 20 years ago, 10 years ago as well, before bone tumor ablation became very popular. That referral base for us and for most people was a very similar referral base to your kyphoplasty. A lot of these patients may come to the ER or they may get seen by a hospital. So it's not necessarily all oncologists. We use that in the spine to educate our oncologists. Your patient was admitted. We use that to educate the radiation oncologists. That did increase the acetabular work, but in all honesty, the referral pathway for that is a little different because it's a more complex area and they tend to get seen more often by orthopedic oncologists. So that was, we will see certainly more with a collaborative relationship with the orthopedic oncologist, which is what we've developed here.
Excellent. And so you alluded to this just a moment ago. Tell us about, just from 10,000-foot view about why is it that the acetabulum is kind of the next site to go after? As you alluded to, there's a very important biomechanical nature of it. And so you're more likely to be doing some ablation and cementoplasty of an acetabulum versus, say, a pubic ramus. And why is that? And what kind of consideration goes into these cases?
Sure. So, not to simplify the acetabulum, I mean, in reality, it is more complex than a spinal lesion because the spine really essentially has one issue, and that's axial loading, right? So a lytic metastasis, you have axial loading, put cement in there that has great properties to protect against axial loading, while the acetabulum also has a lot of axial loading. There is some torsion and shear forces as well. Now, not nowhere near like what we're talking about in a long bone, like in a femur, where cement typically is just really not going to be enough. So in the acetabulum, certainly in the superior acetabulum and with smaller lesions, not huge lesions, cement alone can suffice. So it is, a lot of the bone tumor ablation, certainly in the Opus 1 study, like we look at that and 97, 98% of those patients were augmented afterwards. So, it's the same technique, just in a different area. You compare that to like the Motion trial, which also had very few acetabular cases. I think they had 68 patients, only 2 or 3 were acetabular. You look at that, but they had a large number of peripheral skeletal cryos. So, why is that? Well, I mean, although you can use cement after cryo, it's a lot more challenging, right? So the acetabulum, I think more interventional radiologists are using, for the most part, certainly in the spine, far more people are using RFA or heat energy and the benefits of that working with cement, right? Because we know cement, it sets in heat, and we have evidence that we have less leaks. So we're able to fill a cavity better with cement. So the same applies to the acetabulum, where there are certainly less torque forces, less shear forces than what we see in long bone. So, I think it's really kind of a sexy area to get into, and it's, it's something that's exciting. It's, you can use a lot of different technologies to get your access. And, you do have to really have a better idea of your anatomy, because it's not, unlike the spine, it's not essentially the same thing every level until you get down to the sacrum.
For sure. Yeah. The acetabular anatomy is so complex that I feel like at this point in my career, having spent a fellowship that really focused a lot on that area, I'm finally starting to appreciate the three-dimensional anatomy a bit more. And that's after, 4 years of diagnostic radiology residency. I feel like it took a long time to go from just looking at an AP image of a pelvis to actually being able to appreciate the 3D anatomy and the different curvatures and everything. And so that, along with the biomechanical rationale that you stated really well, gets us into thinking more orthopedically, more biomechanically. And I'm curious, you mentioned the collaboration with the orthopedic oncologists in your system. How did that development of those relationships go? Because typically, the most orthopedists in the community, their interface with IRs might be sending them some joint injections and stuff like that, kind of more typical pain stuff, which might be similar practice that other pain doctors have collaboration with orthopedists with. This is something that, even though it's been reasonably well described in our literature globally, at the community level, as you said, this is something a little sexy, it's a little more sci-fi, and we have to be able to speak the language of orthopedists to branch into this area. Can you talk a little bit about that?
Yeah, I mean, you couldn't have stated that any better, Jacob. You definitely do have to speak their language. So, we have two guys who I work with, and they don't work with each other too much, but they both work with me. They definitely want to know that you understand the anatomy, that you understand the biomechanics, that you're not going to take somebody, I mean, most of the literature is on Harrington 1 and 2 lesions, right? You start getting into Harrington 3 or complete dissociation. I mean, those are going to be rare for me to treat unless there's, the patient's not ambulatory at all, and that's not an issue. So, I mean, just going back to your question, yeah, from a working with them standpoint, I mean, for me, I approached them first. One of them was very interested in talking to me, especially because almost on every case, even in my opinion, when it's not necessarily all that big and a risk for bleeding, but for every thyroid met and every renal cell met, he's calling me asking to embolize first. And he likes to give me a lot of heads up notice, so I'll get the call 12 o'clock Sunday night for a Monday 8 o'clock case, that kind of thing. But it's really respectful of our time and my team. But yeah, I mean, so we scratch his back with that. We get some interesting embolizations, but he has been very open to treating these patients, for us to treat these patients. And in all honesty, I mean, it's not like, listen, I'm not going to get, I mean, we do get occasionally some younger, healthier patients, but usually you're going to get the patients that they're less likely to take to the OR, right? So, I mean, the majority of the patients are, he's started to send me like, this is small, let's do this. And if it fails, I'll do a hip replacement, right? That kind of thing. But, in reality, I mean, sometimes they're obese or their performance status is not the best, or they just can't be off their systemic regimen for several months, in which case, yeah, I mean, they are realistic and we've had good outcomes. I mean, I think part of that, though, is not taking on, I take on some high-risk cases in the spine, and I'll take on a high-risk case in the acetabulum, but I'm not going to fight him for a case that's a real high risk that he can easily, go to the old way.
Sure. Really well said. And, I think it's in the DNA of interventional radiologists to want to wear the cape and do the heroic cases. And as our friend Alan Sogg has said, one of the most important things when you're building up relationship with new doctors, especially around these new procedures, is knowing when to say no. I think that is really important, and really important to build a team who can support you and not feel that you're necessarily being forced to do something. So you alluded to the Harrington classification. I think this is a really good thing for us to talk about in terms of knowing the language of our orthopedic colleagues and being able to assess when is a case a good candidate for this ultimately minimally invasive technique. Could you break that down for us a little bit?
Absolutely. First, one thing about the Harrington classification that's important to remember is just because there is a lytic lesion in something doesn't mean that it's completely not intact. So, just having any lytic lesion in the superior wall doesn't necessarily classify it as a Harrington 3. But when it's completely deficient, so the lateral cortex deficient would be a classification 1, but those superior and medial, which are the most important, and that would make sense, right? The superior has axial loading. If you have an acetabula protruso, that's going to be the medial wall. So level 2. So Harrington, so that's 1, where the lateral cortices are the ones that could be deficient. 2 is the medial wall could be deficient. 3 is superior and lateral are deficient. And then 4 is something that you're essentially not going to see. The vast majority, if there's not a ton in the literature, I can tell you the ones in Opus 1 were all Harrington 1s and 2s. The ones in Motion were the same way. If you look The majority of the ones above 2, so you start getting into 3 and certainly 4 and 5, which is total acetabular destruction, either have some sort of rebar, basically, right? So we have some sort of internal fixation for those patients.
Not a good first case.
No, not a good first case, and frankly, not really a good second case. I mean, you know, the acetabulum is can be frankly fairly easy. You get a small hole. I mean, you know, my first 5-10 cases were, 2-3 centimeter lytic lesions. You stick a couple of probes in there. You make sure you protect the joint. You have to. There are certain procedural things that you have to be careful about, in addition to avoid AVN, and then you fill with cement. But yeah, they can get really complex. You do have to, unlike the spine where the nerves are always in the same place, in the acetabulum, you have to really know your nerves, right? So you have to know that there's, basically 4 nerves there. You have to know your 2 anterior nerves. You have to know your 2 posterior nerves, where they're going to course, and, theoretically, what kind of disability will occur if you hit them. Now, we have a huge advantage with ablation because we have, whether you do it in fluoro, cone beam, or CT, not really fluoro, but if you have the ability to have cone beam or CT, you will know where those nerves are going to be. Right. So.
Right. Absolutely. And a great segue to talking more about the technical approach, getting into the nitty gritty of the procedure itself. As you alluded to, kind of the main choices of modality would be CT or cone beam CT, fluoro, kind of augmented fluoro setup. So dealer's choice, which one do you prefer?
Cone beam CT all day long. So I would say my first 10, maybe 20 acetabular cases I did in CT. A lot of my first sacral cases I did in CT. I have done almost every one of those now without fail in using cone beam CT. So number one, the cone beam CT, especially with some of these complex acetabular lesions, you have to choose your route, right? The cone beam CT, a lot of the, Philips, Siemens, GE, they all have really good guidance technology that makes the procedure faster and easier, and you can sort of go back and forth between that and fluoroscopy. The other part about it, but you have the CT part of it so that you feel more comfortable about, external structures. I mean, like, I wouldn't, for your access, that's great, but after I access, before I ablate, I will always get a cone beam CT. That's just the way I practice. I'm always going to get a cone beam CT before I ablate these patients. The other reason why I find it to be easier to do cone beam CT is the cement portion. So
Absolutely.
The cement portion
of
this, is equal or not, is equally important, at least, as the ablation, right? So the cement portion is so much easier than what you do in fluoroscopy than in CT. Number one, you're going to see joint space leaks much faster. You're also going to see things that you might think are joint space leaks, but you can much more easily prove it, right? Because, what I always, when I'm teaching courses, I always tell people, if you can put something in in a space. So let's talk about the joint. So if you leak cement into a joint, it's not the end of the world. Oftentimes it can get taken out arthroscopically, but a lot can be a bigger deal. But if you can put cement into that space, right, with fluoroscopy, it may or may not be there, right? You can always get overlap. But if you can take it out, it can't be there, right? If you can take it out of the space, so getting those obliques, getting the joint space into, sort of like en face in a way where you're seeing the cement go up to the joint space, that is so crucial. And this is an area where you don't want to under cement. So why did I move from CT to fluoro? Because I under cemented. And once you under cement, you're either reaccessing and you're going through cement to reaccess, which, Jacob, you're shaking your head because you've done it before.
It's doable, but not fun. Not fun.
No, not fun at all. Not fun at all. And, it's a real challenge to do. So, or you're under cementing and you're putting that patient at risk. I mean, there's just nothing worse than a small amount of cement because it's just going to fracture right down on there. So, yeah, that's what led me to leave CT. I do have one partner who brings in a C-arm and CT, and I think that's ridiculous. The cone beam CT today, is so good. Just, remove your inner stylet. When you're getting your pictures, you're going to get a great picture. You're going to see what you need to see. You can guide the case. It is so much faster, so much better. And the techs get really good at doing it, too, after a while.
Oh, yeah, for sure. And I think these are very fun cases. I have yet to meet an IR tech who doesn't like a nice needle guidance case. And these are kind of the king of those.
They beg for it.
Yeah,
they do.
Exactly.
I was just at one of our other hospitals, and they have the capability. They always had the capability, but they just got a new Siemens machine, and they're like, "Can we do it on?" So we had a bunch of sacral ablations, and they're like,
awesome.
"We want to do it on every case." All right. So we did three guidance for them yesterday.
Awesome. And now that you've done loads of these cases, do you find that the acquisition of the cone beam CT and planning the trajectories, are you able to do this in a pretty expeditious manner?
Yes. I mean, I'm certainly a lot faster than I was. And I would say yes, for the most part. We have, unfortunately, two different systems at our two hospitals. So our main hospital have Philips. So with that, yeah, I can do it really fast. At the hospital that I, for instance, was at yesterday, they have Siemens. So I kind of rely on my techs a little bit. So they enjoy those cases. And like you said, I mean, I think they don't like me as a person, but they like the cases.
And you keep them fed, so that's what they care about. Yeah. So going back to the kind of the first step in terms of access, is your access with a standard kypho needle? Are you using essentially, for the most part, kypho equipment?
Yeah, mm-hmm. I mean, every once in a while, if you're going through the pubic symphysis as strong as you think you are, I mean, oftentimes you may need to pull out a drill. But in the absence of that, most of the time I'm just using a standard access, a kyphon or a striker, whatever, standard bone access needle, and, using my coaxial set for 99% of the cases. If not, then, if I have to use a drill, then you use a drill and, you get back it down the same hole with the access needle.
Sure, yeah. And Dana Dunleavy has told me about a technique he used, which was kind of a Seldingerized use of a drill and then putting a wire and then being
like
able
a K-wire.
Yeah, exactly. It's very, very simple and yet elegant way that, relies on a lot of the techniques we use every day. And so you mentioned that a lot of these are going to use multiple probes. And so how do you go about kind of choosing your trajectory, choosing how many probes you're going to be using?
So my trajectory is, usually it's going to depend a little bit on the patient's body habitus, right? If they're huge, you may, coming from a lateral approach may be a challenge. So I choose my approach, typically it's going to be either direct anterior, a direct lateral, or coming through the, my more inferior approaches, I may go through the pubic symphysis, right? The inferior pubic ramus, or go through the ischial tuberosity from a posterior approach would be my approach. And it's going to depend on where the lesion is and where I want to end up. And many times I may do, have a couple of needles, in all three location, right? So the access will depend obviously on the location of the lesion and the patient's body habitus. The number of needles is going to depend on, obviously really essentially the size of the tumor. And then in general, like I said, sometimes at the end, and I have a couple of cases where I show that sometimes in the end, I will ablate, cement, and then I will reaccess. If I don't feel like I have enough cement in there, I will reaccess and put more cement. I'm not going to leave an acetabulum under cemented.
spoken like a man after Doug Beal's heart. If you don't have enough cement, you re-access and put more cement.
Yeah, I mean, just if you do enough of these, you learn why you shouldn't do that.
Sure.
Why you should do that, why you shouldn't under cement.
Absolutely. And of course, we've all seen the vertebral compression fractures that have gone to further compress around an inadequate amount of cement. The same thing can happen in this area. So,
absolutely.
And you spoke quite a bit about the leakage of cement. I think this is that's probably kind of the most feared complication of this procedure. And so you mentioned using judicious fluoro to get your joint laid out on FOSS. And so that's kind of your analogous to our lateral view, and the spine being our safety view for the most part.
Yep. And it's a real-time view too, Jacob. It's not, you get it on FOSS, but I'm doing it real time, similar to like a sacroplasty. A lot of times if you're worried about, sacral foramen, you're going to get your off axial view. You're going to be going down your SI joint view, your AP, back, forth, but you may be just real-time fluoro just to make sure that you can see where that joint space is and how close you are, and just keep filling. Listen, the vast majority, just like the spine, the vast majority of leaks are completely meaningless, right? I mean, the cement's hot. I mean, if they're really thin and, it could be, irritating, on the skin or something like that. But the vast majority of these, the only real leak issue you're worried about for the most part is just going to be into the joint space. The guys at the Mayo Clinic, Kallstrom, and those guys that had a paper in JVIR a couple of years ago where they were using cryo, which, I don't love doing. You have to wait 45 minutes. They actually, back in the day, they used to bring them back the second day, which is a lot. Wouldn't work in my hospital. But they used balloons, right? So to keep the cement. But remember, I mean, once you do radiofrequency ablation, I mean, there have been retrospective papers with radiofrequency ablation. We get less leaks. It's the spine. It's no different in the acetabulum. I always say this. I would never do a kyphoplasty in a patient with a completely blown out posterior wall, right? Because it's going to leak. I would never do a vertebroplasty, but I would do a combined kyphoplasty with an ablation because I feel so much more comfortable where that cement's going to go. And I can be so much more aggressive and get so much more cement in there that I'm really happy with, what I get after an ablation. And the same properties work for the acetabulum, and the same, theory of that axial loading is important. So as long as you're not taking on 6 centimeter tumors, you're going to be good, with cement and real-time fluoroscopy, avoiding that joint space.
Absolutely. Really well said.
And you can do some of that thing, by the way, with balloons. You can, I've done it before where I'll like blow up a balloon as a blocker if that superior wall is not completely intact, and,
Gotcha.
hope that it won't go down.
But for the most part, in the context of the cementoplasty here, you're not usually needing to use the balloon there.
Nope.
Awesome. And so talking about other potential complications, I think you mentioned this earlier, potential for avascular necrosis in the femoral head. And I saw this in the literature described more so with cryo, because as we know, it can be kind of hard to, you can get overconfident in knowing where the ice ball is. And we know that the ablative field actually extends a bit from that. And so there have been reports of going into the joint, damaging the femoral head, and so on. Is this something that happens with RF as well?
It does. And there's really two methods where it can happen. Obviously when you're doing your ablation. So first you have to worry about, chondrolysis, articular cartilage, right? So you've got that can happen with hot, that can happen with cold. Okay. So, there's no decreased risk. I mean, well, that's not entirely true. I mean, cryo will cross intact bone much more easily than radiofrequency energy. So you do probably have more safety with radiofrequency ablation in general. So that's one. People will put contrast into the joint space, forgetting that there's an articular surface on the acetabular side. So, you still will get that. As far as theoretically, though, that, the direct extension with AVN of the femoral head, I would imagine that putting in some fluid into the joint space and keeping it cool for radiofrequency ablation, or keeping it hot for cryo, those are theoretically benefits to reducing your risk of AVN. I'm a personal believer that many of the cases of AVN may be related to, and there's the belief that the round ligament artery supplies the medial surface. For those of you who are doing prostate embolization and you're starting to learn more about those arterial branches, it comes right off the obturator artery usually. And if you hit that, not that you're going to see it, but if you knock that out, you can get AVN. So I had a personal case where that happened. I showed it around to a couple of friends, and it's really just a real medial placement of medial and inferior placement at the superior acetabulum, where you can get yourself in trouble with that. So, listen, the bottom line is it's rare we're doing this in a curative setting, right? I mean, those we're doing this in a palliative setting. So chasing every bit of the tumor with radiofrequency energy, while that it would be great and definitively in the long term probably is going to reduce your risk of complications, right? Or fractures or tumor ingrowth or anything like that. The risk goes up as you start chasing more and more of the tumor. So I do try to avoid full ablations right on that medial surface after that happened.
Excellent pearl there. Really good to know. And speaking of the thermoprotective techniques, you mentioned some of these. I'm gathering you're not using these routinely yourself.
No. In the acetabulum, I would say it's very rare for me to use that. So there's the protection things, where you can put fluid, you can put balloons, you can do a bunch of different things to, hydrodissect or put air in there, put CO2. And those are great. And those are, in my opinion, more soft tissue ablation things. I also, in turn, don't use a ton of neuromodulation. I think, again, most of my acetabular work is going to be with radiofrequency energy, and it's unlikely you're going to burn a nerve without the person feeling it. Right?
Sure. And so on that note, you're doing most of these cases, if not all of them, under moderate sedation.
So I do my spines that way. My acetabulums, I don't.
Okay, got it.
I don't do them under general either, but I'm always using MAC on those cases.
Got it. And is that just to keep them a bit more still?
Yeah, the axis is harder than in the spine. It's not just dink, 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 you're in, and 30 seconds later you're going. These are a little more challenging than getting into pedicle, right?
Sure.
For the most part, I keep them more heavily sedated.
Got it.
But yes, that is the way I do all my spine work.
Got it. Good to know. And there was one more thing I almost forgot to say. Speaking about these thermoprotective techniques, I was doing a little bit of reading in preparation for our discussion, and I came across a very interesting article, again, from our friends at Mayo Clinic, this one from Mayo, Florida, from Hillary Gardner and the crew there. They were discussing how some of these, the thermoprotective techniques, a particular carbon dioxide, doesn't actually insinuate very well between the femoral head and the acetabulum. Tends to kind of pool around the head and neck junction. And so they came up with what I thought was a pretty brilliant way of making this more effective. They basically applied distraction to the hip using just an old school orthopedic kind of dumbbell on the end of the table setup, able to put a little bit of force to traction on the hip and open that joint a little bit more. And they showed on CT that actually if you're using CO2 as a protective thing, and of course they were doing cryo in this case. But anyway, I thought that was really fascinating and just wanted to bring that up. And
that's really
give
interesting.
Some credit.
Where
give
was
some credit. That was at Mayo, Florida.
No. Where was the article?
I'll find it. I think it's probably JVIR, and I'll send it to you. And
that does sound familiar. It's
yeah,
but
really,
that's
really cool idea. So I'll send that to you, and we'll get it on the show notes as well for this episode.
That's great. Yeah, that's like one of the great things about doing interventional is we get to do like just cool things like that, and then you bring something to your lab, and everyone thinks you're so brilliant, even though you had nothing to do with the idea.
Yeah, absolutely. I can steal ideas with the best of them, and so, but I love those kind of simple ideas. It's like the saline glove filled with hot water if you're doing a soft tissue cryo and those kind of thing. And so we've really talked about almost all the questions I had here. And so my next point was just kind of general pearls and pitfalls. We've discussed so many of them, but are there any others you don't think we've discussed yet?
One thing, where is the magic number for, in a patient that's going to be ambulatory, has decent levels of activity? Where's that magic number where, they do need mechanical fixation, where cement alone isn't going to be enough? And the honest answer is we don't know, right? There is no magic number, right? There are people who need to be treated. It's certainly not 6 centimeters. It's going to be less than that, right? And it's also not 1 centimeter. The person, at least my opinion, who does the most internal fixation is probably Sean Tutton. So what he always tells me is, he uses 3.5 centimeters of a full defect, and he's going to fix those patients if it's bigger. He's got a great setup where he's working with his orthopedic surgeon. I think it's, a great setup. I don't know. It hasn't been happened at too many places, but he's got a great setup where, and it's not, he's not the only one, but he's got a great setup where they've able to work together where they'll do a couple cases in a day.
Yeah, it's great. And of course, our friend Tony Brown has showed more recently that this is adaptable also to the community situation. He has a close working relationship with his orthopedic oncologist as well. But I think this gets back to what we were saying earlier about making the right call and not putting yourself and the patient kind of above your heads. And so it's always okay to say no. It's always okay to say this is a bit much, and know when you need to, if you're going to tackle something really tough, know when to team up. And that's one of the things I really was interested in getting across with this discussion is a more collaborative approach that interventional radiologists can have with orthopedists. And so, as you said, orthopedic oncologists are really going to be most attuned to this work since they're seeing these patients and everything. But a lot of these principles of pelvic fixation have their roots in orthopedic trauma. And so I think it's great to talk to the traumatologists as well and get their sense of biomechanics and when to use a big screw, when to use a bigger screw, when maybe you don't need to use a screw. And so, as you say, you personally don't do any of these, but if something comes your way, you would know when to say, okay, this is a little bit out of my wheelhouse. And we have a few colleagues across the country and across the world who have built really excellent practices doing the internal fixation type of cases. But we've talked so much about acetabular lesions today, minus that. And so even if you aren't in a setup where you can readily adapt that, there's so much that you can offer to these patients who have these lytic lesions.
Absolutely. I mean, it's not infrequent that we're treating these, whether they're small or, and keep in mind, like, it's not like I won't treat larger lesions, but usually those are patients, who just aren't surgical candidates. They're not, so our orthopedic oncologist will have me cement those, especially somebody who may not be ambulatory. It's really just pain relief. Those patients are typically more at the end. But yeah, you have to need to be aggressive, but not too aggressive. It's walking a fine line.
Right. Walking the fine line and developing that sixth sense of when to avoid complications and walking right up to that so you can help patients who really need your help the most. So Jason, I think we just about beat this one to death. This has been a lot of fun. And I'm excited a lot about what we talked about, especially this is something that I'll be trying to get up running at my place, hopefully in the near future. So certainly have a lot to think about and a lot of pearls and pitfalls. Do you have any final words you'd like to share with the audience?
No, I hope people are excited doing this stuff. I think, we got to keep on fighting the fight and getting these. We got to, the acetabulum is no different with some of the radiation oncologists. I mean, they're a group, in my experience, that have been more challenging to be collaborative with. But, the reality is if, just like in the spine, we make them better. So their patients will lay flat longer. These, they're not going to get skeletal related events, right? They radiate without us on these lytic tumors and they're going to run into problems. So we have still a lot of work as interventional radiology and people doing these procedures. We've got to continue to push the envelope with this. We got to keep treating these patients. We got to focus on the palliative team, on the oncologists, the orthopedic oncologists, and unfortunately, more and more the payers, right? So, that's, a challenge that we're starting to see with a bunch of payers. Even recently, I've heard Aetna is now, unfortunately, starting to deny more ablations. So we'll be dealing with that on a societal level.
Very frustrating. And we do have active societal efforts from several of our different societies. And of course, we do have the benefit now being included in NCCN guidelines. But as with any kind of groundbreaking technique, the knee-jerk payer reaction is going to be no, 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 no. And so we'll keep up the fight and bring these treatments more into the mainstream, just like has happened with kyphoplasty taken to the brink in the late 2000s and due to the work of many people, including you, Doug Beal, and many others, the advocacy has made it so we're really able to take care of a lot of patients with this, but the fight never ends, and we'll keep it going.
No, I agree.
All right, Jason. Well, thank you so much for joining tonight, and to our listeners, thanks for tuning in, and we'll catch you next time.
Thank you.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.